Good afternoon. Thank you for joining us for this program, Antipsychotics and Long-Term Care. Protect your loved ones from unnecessary drugging. My name is Claire Curry. I'm an attorney at the Legal Aid Justice Center, where we have our group called the Community Partnership for Improved Long-Term Care. This show is very important to you, so I hope you will stay tuned and learn what you need to know to protect yourselves and your loved ones. We have a wonderful panel here today of folks who have decades worth of experience in long-term care. And if you don't know someone in long-term care, a nursing home or assisted living right now, and you're tempted to turn off your TV, please resist the urge, because I can assure you, you will know someone at some point who is in long-term care. And if you do, you are going to run into the problem of antipsychotic drugging. I'd like to introduce our panelists. I'd like to start first with Emily Chewning. She is a family member who cared for her late father for many years and in many different care settings. And she has experiences that she hopes by sharing with you, you will be in a position to protect your loved ones and yourselves. Our next panelist is Love Berkley. Thank you for being with us today, Love. Love is a nurse in a long-term care nursing facility and has many, many years of caring for residents, and she's going to be sharing from her experience and her expertise on this issue. Finally, I'm very happy to have with us today Mary Evans, who is a physician. She's been a medical director in a number of different nursing home settings, cares for patients, I think, in other settings as well as nursing homes, and has been an advocate for her patients and their family members on the issue of antipsychotics, I think, for many, many years. So thank you for being here today.
Thanks, Claire.
I think we'll start off first with Emily Chewning and get the family perspective on this. Emily, I think I've heard you say that if you knew then what you knew now, that things might have gone quite differently for your father. So I'd like you to start us out on this conversation by sharing a little bit of your story, please.
Thank you, Claire. I would like to do that. I'd like to tell you the story about my dad. It's highly likely that you or a family member will face the prospect of caring for a loved one who has dementia, even Alzheimer's, and I don't want the same thing to happen to other people that happened to my dad and our family. So his story is important for that reason. His name is Charles Chewning. And when he was about 75, he developed symptoms of dementia, and our family realized that we would have to work together to take care of both my mom and my dad in that situation, which was okay for a number of years, but finally it came to a point where they needed more help. So my mom and dad moved up to live on the same property with my husband and myself. And we wanted the best care for him, so we took him to the memory disorder clinic of a major nationally known medical institution where we thought for sure they would be able to help us give us suggestions or whatever. And immediately they put him on these antipsychotic drugs.
So that was the first thing they did?
Yes, actually. It didn't take long. They checked him out and put him on the drugs.
Wow. And
we began to notice some things. His thinking was muddier. He slept more than usual, and it was a different kind of sleep. It was more of a drugged sleep, I mean, to be honest. And his walking was more difficult. He fell more often. And so we went back to the clinic periodically, and we reported these things to them, and they said, well, you know, he's getting used to the drugs, and they're supposed to make things more peaceful and more mellow, and it's going to work out, and some of these symptoms belong to the disease itself, the progress of it, et cetera, et cetera. We continued to ask these questions, but looking back on it, our family realizes that these were direct results of the drugs that he was on, and we could see he went downhill much faster than he may have, and really, truly, he had to be institutionalized, and I think much sooner than he should have been because of this.
Sounds almost like the drugs took your dad away from you.
In a way, they really did, because we lived in a place where he could get a lot of joy from things that he loved in life. It's on a farm and watching the birds and taking a walk, gardening, all of those things were taken away from him.
Well, thank you for starting off our discussion, and it's very sad, and I'm sorry for what happened, but I'm so pleased that you're willing to share your experience on this panel, and hopefully the viewers will learn things that will help them be able to prevent, what some of the things that your dad suffered through. I think at this point what we need to do, since many of our viewers may not know what exactly is an antipsychotic, whether they're on one, if you don't know what it is, it's hard to know if you're even on one. So I'd like to turn now to Dr. Evans and basically ask you to give us a 101 antipsychotic course, just an introductory level. Share with viewers, what is an antipsychotic?
Okay, well, what we're talking about today is atypical antipsychotics, is a name for several medications that are used in elderly people and in nursing homes. Some common brand names are Seroquel, Risperdal, Zyprexa. Those are the most commonly used atypical antipsychotics. And they're actually FDA approved for schizophrenia, bipolar disorder, Huntington's disease, and Tourette's syndrome.
So that sounds like it's a drug meant for serious mental illness. Is that fair?
That's right, Claire.
Okay.
And what we see in long-term care and in treating the elderly is that a lot of elderly patients are put on these medications without those indications. They're frequently started on those medications either while they're in the hospital after having an acute event like a fall with a fracture or a serious illness. And then they're often continued on those medications after they're hospitalized.
So if you end up in the hospital and you're put on these drugs, but you don't have a severe mental illness, what are they being used for? Why would the hospital or the doctor or whatever prescribe an antipsychotic for you if you don't have one of the 4 diseases you mentioned?
Well, unfortunately, these days in medical practice, those medications are used for other indications. Sometimes they're used for patients who just have trouble getting to sleep. We find that these drugs are being prescribed for sleep in older people. Also, a lot of older people, when they're in a hospital, they're in an unfamiliar setting, they're with unfamiliar caregivers. Sometimes they get very scared and agitated. They may yell out or strike out or be combative at different times, which with an older person may be normal behavior in that type of setting that they're not familiar with.
And I'd like to interject that in the case of dementia, because of the reduced mental capacity, that same kind of agitation can crop up. And my take on it after the fact with respect to my dad was that this clinic felt that this drug would, they say mellow him out, but what they really mean is keep him drugged so he wouldn't become agitated. The fact of the matter is, he was fearful, from time to time, really fearful. And so the drug actually just exacerbated the whole thing.
It sounds almost like if the drug is being used that way, it might be to sedate or make you almost be like in a zombie state where you follow rules and behave and are quiet. Is that what you're saying?
Yes,
Okay.
it is. And I, looking back on it, I realized that's what it was all about.
Okay. Thank you for naming some of the common ones, because people now, at least, they might know the names of some of those drugs. Abilify, what did you say? Seroquel, Risperdal, Zyprexa, and there are others, but you can be aware of what drugs you're on and go look, see what the drugs are and see if you see any of those names. I would like you to talk a little bit, if you would, and Love or you, Dr. Evans, if you would tell us about the risks of the drugs. I understand they have something that's called a black box warning.
That's right, Claire. The FDA a few years ago, the Food and Drug Administration, came out with a black box warning for this class of medications. And basically, it's a very strong warning that's put in the packaging material of the medication. Some studies have shown that there's a significantly increased risk of adverse events, including death, in patients who are older and who have dementia. And they're specifically warned against using those medications in older patients with dementia.
I've heard that this is the most serious warning that the Federal Drug Administration puts on any prescription drugs. Is that true? The black box warning is this really serious warning?
It's a very serious warning. I mean, short of pulling a medication off of the market, that's a very serious warning.
Okay, that's great. Now, when we began the program, I said we were going to focus on long-term care. We've talked a little bit about how you might get put on these drugs in a hospital. How about in the long-term care setting? I mean, a nursing home often, that's the home of the resident. Like when Emily's dad could no longer be cared for at home, he might have gone in, he did go into a facility. So that's your home. How does it turn out that people are put on these drugs in long-term care?
Well, I think because they come from the hospital, they're on the drug. And if you don't have doctors that are and nurses that are looking at the meds, you can approve the meds and get them done quickly through a doctor, but you have to look at the diagnoses for the patients, make sure they have a diagnosis for the medication, then talk to the doctor, and the doctor talks to nurse and staff to make sure that the medications that the hospital has put them on are appropriate for them.
Mm-hmm. And am I right, Love, you've been working in a nursing home setting for a long time?
8 years now.
And so have you seen antipsychotics used on residents in nursing
We have
homes?
a lot of patients come in on them. And then it's the doctors that we gradually reduce the medicine from them, so to get them off the medicine.
Does your facility have sort of a philosophy about the drugs, or trying to do anything around this whole issue of antipsychotic drugs?
We do. We don't use antipsychotics in our facility unless they have the diagnosis. If they come in with the medicine, we talk to the families, which are sometimes hard because the hospitals put them on the medicine, they see a change in their loved one. Sometimes it's a good change for a while because, their loved one isn't fighting. They're not agitated. But then at the same time, you see the adverse reactions to it also.
Right, right. So a family member actually, if they haven't gotten the information they need about these drugs, and you mentioned some of the very dangerous side effects, they might actually be looking to the nursing home staff and wanting the drugs. Am I right? They might want them continued?
Correct.
Tell us a story about that. I mean, does that actually happen, and what's it like?
Well, they want their loved one to be calmer. They don't, it's hard for people to deal with people with dementia and seeing their loved one not know who they are anymore. And,
Right.
The medicine gets them back to a little bit of what they were. So you have to educate them and sit down and talk to them. There's actually legal consents that they're supposed to be given to show all the black box warnings, to know when their loved one is being put on an antipsychotic. We're also mandated through CMS to make sure that there's no patient on an antipsychotic without a diagnosis.
Let me interrupt you because some of our viewers may not know who CMS is. That's okay, that's okay. CMS is the Center for Medicaid and Medicare Services. They regulate all the nursing homes in the country that accept Medicare and Medicaid, which is virtually every nursing home in the country. There are some that don't, but almost all do. So if you've got someone, and anybody can jump in on this because from the family perspective, from being on the inside, and from being the treating physician, if somebody is in a nursing home and they're agitated or frightened, as you described, or their behaviors are such that it's challenging for the family or the staff, what options do you have?
Well, Claire, we like to look at the patient as an individual, as a person. And if this person were not in a nursing home, you would probably not think the first thought to put a medication on board with them. If someone, either with dementia, or sometimes I like to use the analogy of having a child who's in a daycare center. if you were a parent and you showed up at the daycare center at the end of the day to pick up your child, and the daycare center caregiver said to you, well, Claire was acting out today. She had some behaviors today. And so we went ahead and gave her a medicine to calm her down. And she's been sleeping for the last 3 hours. As a parent, I imagine you would be outraged that
I
this
would be
happened.
on the telephone to Child Protective Services.
Right.
Immediately.
So when we take care of residents in long-term care, we're taking care of all their needs, not just their medical needs, but their social needs and their emotional needs. And so when you're looking at somebody, we look at residents who are having behaviors as, you know, if they have dementia, they probably lost the capacity to communicate clearly. And we look at behaviors as being a form of communication. And our job as caregivers is to try to figure out what they're trying to tell us. So the first things that we look at are the common things, like is this person cold or hungry, or do they need to be changed or go to the bathroom? Are they bored? You know, are they irritated by somebody? So we look at those common things first and try to address those needs because those are relatively easy to fix.
It seems to me, and I'd just like to know from you all's perspective if it's accurate, that oftentimes the behaviors that you are talking about that a person might get agitated are not just out of the blue, but that they occur when others are trying to do something to the patient or resident. Can you all comment on that for me?
In my dad's case, he couldn't always figure out why people were doing what they were doing. And it may have been something that was needed, but he couldn't interpret it. And I found that it made a huge difference how he was approached. It was very straightforward. And I also found that the caregivers who knew him best knew not only the things that would trigger his fears, but also the things that would alleviate his fears.
So can you give us an example, like something from your dad's history?
One of the events that kind of encapsulates that, I received a call from, at this time he was in assisted living, and I received a call from the caregivers there saying that he was having a very difficult time and they didn't know what to do with him. Right there is it's important to remember that phrase. And so could I come over? And of course, I immediately went over there. And when I got on the elevator, went up, and when the elevator doors opened, I looked upon the scene with my dad and the caregivers, and he was sitting in a big old chair, obviously very upset. And there were, I know 4, it could have been maybe 5 caregivers standing around him, standing up and around him. And I knew immediately that he was very